All right, so what we have here are two spot images from a contrast enema examination. The first thing I notice is that the contrast is predominantly seen in the rectum and visualized colon, but it doesn't seem to pass beyond the mid-transverse colon. This raises concern for a stricture or even an obstruction at that point. Looking closely, I can also see at least two further strictures within the visualized bowel. One of these strictures appears in the lower transverse colon and shows a large, irregular filling defect. This finding immediately makes me think about a neoplastic process, possibly causing multiple strictures. As I continue examining the images, there's something else that catches my eye. There are widespread sclerotic bone lesions seen throughout the pelvis. These sclerotic lesions are highly suggestive of bone metastases. Now, in the setting of a known cancer history, this would make me lean heavily toward metastasis as a cause of both the bowel strictures and the bony changes. At this point, I think it's reasonable to start considering the likely source of these metastases. Given the pattern of sclerotic metastases, breast cancer becomes a strong possibility. Breast cancer is notorious for causing sclerotic or osteoblastic metastases, particularly to bones. However, before jumping to conclusions, I want to acknowledge that we do need to keep other differentials in mind. For example, colorectal cancer could cause the strictures and large filling defects we're seeing here. But if that were the case, we would typically expect more isolated findings in the colon rather than the widespread bony changes. So, in my mind, metastatic disease is still the most likely culprit. Now, an examiner might ask me at this stage, what are the potential non-malignant causes of these strictures? One possibility could be radiotherapy-induced strictures, especially in a patient who has undergone treatment for a prior malignancy. Radiotherapy can sometimes cause well-defined strictures, and it might also produce bone changes that resemble metastases. But I have to emphasize that the widespread diffuse sclerotic lesions really point more toward metastatic disease. I'd expect another question to be something along the lines of, what further imaging or investigation would you recommend? Here I'd suggest a staging CT scan of the abdomen and pelvis. This would give us a more detailed look at the extent of the disease, particularly the strictures, and help assess any other areas of involvement. Additionally, we'd want to investigate the bone lesions further, so I'd consider a bone scan or even an MRI to get a clearer picture of the skeletal involvement. At this point, given the imaging findings, my leading diagnosis is colonic and bony metastases, likely originating from breast cancer. The combination of multiple colonic strictures and widespread sclerotic bone lesions makes this a strong possibility, particularly with breast cancer's known predilection for osteoblastic bone metastases. An examiner might also ask, what else might cause sclerotic metastases if not breast cancer? In that case, I'd mention other primary tumors known for sclerotic bone mets, like prostate cancer or some GI cancers, although in this context, breast cancer remains the most likely source. To sum it up, based on the imaging and the clinical context of multiple bowel strictures and sclerotic bone lesions, I believe this patient is most likely dealing with metastatic disease, likely from breast cancer. Further imaging is essential to confirm this and help guide management. If you found this discussion insightful, don't forget to subscribe to Radiology Made Easy. And hey, let us know in the comments if you've seen similar cases or have any thoughts. Let's keep making radiology easier together.